and we are doing the second part of the two-part presentation. You can see on the screen that the first part included sepsis, cardiac, respiratory, renal, and neuro. We are beginning with endocrine on slide 94. We were discussing this. Did we get neuro done? I can't remember if we got neuro done in the first presentation.
I don't think we did. We just got through renal.
So we'll be starting with neuro, and these are shorter, so we should get through all of them in the next hour without any problem. So let's jump right into it.
Thank you.
Encephalopathy is another hot topic with medical population. It's something we also talked about on the surgical group because there's so many problems with confusion in post-op patients. But it did come back as one of the top 21 opportunities in our audit for the medical population as well. Remember that metabolic encephalopathy is always due to an underlying cause. There are many causes such as brain tumor, cerebral infarction, ischemia, uremia, poisoning, systemic infections. We do not, or we should not be doing queries for encephalopathy when there is only a localized infection such as cellulitis or UTI in an elderly patient. There's no known mechanism by which that would take place. It should only be for the systemic conditions. ICD-10, we do have a new code called F05, and I believe I'll show you that in a couple of slides, that would capture an acute confusional state due to a localized infection, and I believe that's probably what we'll be using. Things that we shouldn't use encephalopathy for in the CDI world that I think in the past has been given out as some advice, maybe some bad advice, would be doing queries for encephalopathy during the post-ICL period, queries for encephalopathy on a patient who is suffering from hypoglycemia. If they have alt status due to severe hyperglycemia, it gets bad enough, we do have the diabetic coma that we could use. And the very short transient confusional states, maybe just lasting a few minutes, those sorts of things I would not do. Encephalopathy should be something that we can, again, link back to a systemic metabolic problem. And if you can, try to avoid using the term toxic metabolic or metabolic toxic. The coders will see the word toxic and they'll go and look for a poisoning. They'll go and look for a medicinal substance or chemical substance that's creating that toxicity, as opposed to having the understanding that it can be due to a naturally occurring substances that are built up in the body and just aren't excreted well or haven't been processed well due to some other organ failure. So in those situations, just the term metabolic encephalopathy and toxic encephalopathy for drug or chemical exposures. So let's look at some of these. We have unspecified metabolic, other, toxic, and hepatic, all are MCCs. Just where we've still got the ICD-9 codes listed here, but beware that in ICD-10, hepatic encephalopathy is not reportable unless the patient is in a coma. The patient has to be unconscious. There's a lot of MCCs there that we'll probably use. For those who haven't listened in the first part yet, maybe listen to them out of sequence, an MCC is a patient who is severely ill versus CC, which you see on the screen, which is just a complicating comorbidity. It's a patient who's moderately ill. For the patients who have an acute confusional state built up as a result of elevated ammonia levels, we should probably consider the diagnosis of just straight metabolic encephalopathy. We're not trying to work around or cheat the rule. It's that in ICD-10, hepatic encephalopathy is not an indexable term until the patient is completely in a coma. So I think metabolic encephalopathy is probably an appropriate alternative for those cases. You notice that hypertensive, alcoholic, ornices, and anoxic are all just CCs or just that moderately ill. I think that's really strange for the anoxic one. Hypertensive encephalopathy is something we have struggled with in the past as well. That is sort of a short-term, transient confusional state that usually reverses itself quite rapidly once you reverse the explode hypertension or the hypertensive emergency, and something, but it will give us that moderately ill level that gets us probably an extra half a day on our risk adjustment. Uspecified is the one that we end up with a lot of times if you just write encephalopathy and don't give any further specificity, and that's okay, but usually we prefer metabolic encephalopathy. So I mentioned this slide already. We'll just go right on through it. This is about toxic or toxic metabolic being reserved for patients have drug and chemical exposure. By the way, this presentation will be on the ICD-10 SharePoint, obviously, so you can refer back to it there. Let's talk about delirium. Delirium and encephalopathy are often used interchangeably in the clinical setting and research. Gone through the literature many times, and there's really no differentiating from a clinical perspective of what the difference is supposed to be between delirium and encephalopathy. The terms are used both in academic articles as well as in some advice that sometimes gets thrown around for coders and CDI. Problem is, delirium and encephalopathy do not get reported as the same type of a diagnosis once they are translated into ICD or ICD-10 codes. The diagnosis of delirium, we go to an acute confusional state, which is basically a sign and symptom. You relate that delirium with further specificity. At best, ends up being assigned to a psychiatric condition, basically falls somewhere between dementia and I think dementia and some other type of acute drug reaction. And so it's basically a psychiatric diagnosis. By the time it gets reported, that's what the insurance companies will see it as, that's what CMS will see it as. So if it's not due to some kind of a psychiatric condition, we probably should be using encephalopathy instead, just to align the reporting with what we know to be the clinical truth. Some examples of some overlap would be drug-induced encephalopathy versus drug-induced delirium. I think that generally I would use drug-induced delirium for a patient who has taken a psychoactive medication, a narcotic, benzodiazepine, a sleeping pill, something like that. Maybe they're having problems with the anesthesia. I think those are all very good fits for the drug-induced delirium. However, if they're taking a medication such as, a diuretic or something, and they get a severely low stim level, and they're on that systemic electrolyte imbalance, that metabolic problem, they end up with an acute confusional state. For that, I would use encephalopathy. Yes, it's due to a medication, but it's not a direct psychoactive substance, so that's when I would default back to the medical diagnosis of the encephalopathy. Be aware that delirium does significantly lower your risk adjustment and your severity level down to either a sign and symptom or maybe just a moderately ill. And so if you're trying to capture the moderately ill, delirium could be an appropriate response, but only if it's drug-induced delirium would it really count in that way. If you get a situation where the diagnoses of both delirium and encephalopathy are being used interchangeably, beware. Most commercial insurance as well as CMS will look at that as inconsistent. We will simply state that it was uncertain if it was truly met that threshold for that highest level of severity, and they'll remove the diagnosis of encephalopathy right off the chart. In some cases, they'll actually remove both delirium and encephalopathy right off the record in that situation. So where we sort of need to pick a diagnosis and stick to it, I think sometimes people will say we'll use delirium as a sign and symptom, almost interchangeable with the word confusion, saying as delirium is sort of the observable manifestations of the encephalopathy, and try to avoid using it in that manner and just go straight for the metabolic encephalopathy if you believe that is the diagnosis. Here's the FO5 that I mentioned we would come to in a few slides, and you can see you've got acute and subacute infective psychosis. I believe this is a moderately level of severity that we're capturing here. This is a C, and I believe that might be an appropriate diagnosis for a patient with a simple localized UTI with a self-limiting acute confusional state that resolves itself with treatment of the UTI and no systemic linkage. I think this might be where we would go. It also gives us direction for the sundowning. Another, I think, problematic example here is when you have delirium superimposed on dementia. We will probably use this code quite a bit in ICD-10, especially until we get guidance as to how all these things are supposed to be defined. But I also think that there are cases where you may have a patient who has dementia and has a clear metabolic encephalopathy superimposed on that. And I would make that judgment is if I know the underlying metabolic connection, I know there's a very, very low sodium, I know they're septic, I know they're uremic, I know they're suffering from liver failure, and I know that metabolic connection, then I would probably interpret that as a metabolic encephalopathy superimposed on a chronic dementia, and I would expect them to improve to their baseline if they were treated for that underlying medical condition. You have someone who has dementia and they seem to be worse, but you don't have any identifiable reason for why they might be worse. I think this delirium superimposed on dementia might be the right diagnosis there, and then that would be we would be reporting the moderately level. So in that case, you could document it that way, delirium superimposed on dementia, as opposed to feeling obligated to write encephalopathy. Okay, moving on. I already mentioned that for patients who have liver failure and elevated ammonia level, this won't be reportable. We will lose that major complicating comorbidity if you go back and report it as just a metabolic encephalopathy in these cases. Let's look at a query. This looks like the patient was probably uremic. They had CKD stage 3 and an AKI superimposed. Their creatinine went from 1.3 baseline to 1.9. They had a pretty low sodium of 128, and they were also hypoxic. We got a number of indicators here that gives us that medical systemic basis for diagnosis as metabolic encephalopathy, probably an element of hypoxia as well. I had to go with that, but the terms that didn't work were delirium, metabolic confusion, uremic confusion. It had just went to confusion, or we might have ended up with that lesser diagnosis of delirium somewhere in the chart. We did metabolic encephalopathy, and we increased our length of stay from 2.5 to 4.7, and we more than doubled our risk adjustment here. And if you go back and look again, and you see that the patient had metabolic problems, respiratory problems, and renal problems, and that's probably an appropriate move to give that patient the highest level of severity and complexity. Okay, we're going to jump from there straight into diabetic manifestations. There are significant changes in ICD-10 that have to do with reporting diabetes. We still need to know, well, backtrack. In ICD-9, we wanted to know if the patient was uncontrolled or poorly controlled. There used to be terms that we used to query for, and instead of doing that now, what we are going to need to report is whether or not they were hypo or hyperglycemic. I think the coder would be able to get that out of the chart in most cases, but if you simply were to write something like arrow up sugar or elevated sugar, something like that, I could see situations where they might, there could be some discussion where they weren't comfortable using the term hyperglycemic, but it wasn't directly stated as such. And that's something we'll need to look at for sure as we move on. We also need to know if it is drug chemical induced or maybe even induced by another underlying condition. Those are secondary diabetes. We've had those codes for a little while now, and we're expanding them in ICD-10. But again, CS and sort of the HO, they want to get at these situations where you've got problems with glucose control that aren't a primary pancreatic issue. And so it is important to note those secondary diabetes cases. And there is other types of diabetes or other situations. So you could have someone who has primary diabetes, but it's escalated out of control because they have to be on some steroidal therapy. So all of that would be nice to have linked for us. Manifestations are an area that I think the documentation historically has been notoriously bad, especially when you have extremity issues. A lot of times with documentation we'll say diabetic foot or maybe even diabetic osteomyelitis. But what the coder wants to know and what we want to know is it diabetic with a neuropathy that has led to this ulcer? Maybe they stepped on a nail, got an infection, didn't notice it because they couldn't feel their foot and it got out of control. That would be an appropriate diabetic neuropathy, and then with the linkage. And that is a much better DRG. It's a much better level of risk adjustment. It gives us about an extra half a day. It's just a high expectation of readmission than just diabetic foot. A better example, and I think usually when we have these ischemic conditions in the extremities, sure, the neurological issues cause not to care for their feet, but the real issue that's causing the ischemia in most cases is the peripheral valve disorder. So if we had the linkage of the peripheral vascular disorder with the diabetic ulcer, cellulitis, even cellulitis, that is even a much better DRG, even again better than the diabetic neuropathy. Neuropathy. So just aware that if you write diabetic PVD, the default in ICD-9 and ICD-10, they see that V is standing for vascular. They see that V is standing for venous. We typically use it for peripheral vascular disorder, but it will default to a venous diagnosis. And I think in most cases what we're looking at with our diabetes is a lot of PAD. So to really get at the clinical truth, we should probably write it as diabetic peripheral arterial disease insufficiency. And we can actually capture some additional linkages of that peripheral arterial insufficiency with the intermittent claudication, the ulcer and gangrene, and those combo codes. We'll get that better diabetic linkage code, and we'll just have captured more of the clinical. It doesn't hurt that we get the higher risk adjustment, the higher lengths of stay, and all of that process at all either. That gastroparesis is another one that sometimes isn't linked. We'll have diabetes in one part of the chart and gastroparesis in another. The coder won't link that automatically. So we need that linkage that it said diabetes with neurological problems, and then the gastroparesis is a secondary. Of course, diabetic ketoacidosis and HHS, those sorts of things will automatically be linked for us. So areas that we haven't typically looked at with coding and documentation that will be coming in ICD-10 would be, for example, diabetes with periodontal disease or other oral complications. And also have a new set of codes for diabetic arthropathies. And I think we've got, and diabetic dermatitis or other skin complications is another one that I left that I think we'll be using quite a lot. So that could just be your simple cellulitis, maybe not of the lower extremities, but anywhere in the body. And there's no ulcer, gangrene. There's not going to be any surgical implantation. I'm not comfortable with calling it diabetic PVD or diabetic neuropathy. We just want to call it diabetic dermatitis. We can now do that in ICD-10. Okay, a new CC or a new way to capture a moderate level severity for our patient is with non-pressure ulcers. So with non-pressure ulcers, that's something kind of new. We're to doing pressure ulcers and diffuse ulcers and giving the staging, and that gives us a fair amount of severity. But also something we look strongly at in terms of our quality of care and whether that was present mission or not. With pressure ulcers, we will get that credit for a moderate level severity when it is located on the ankle, heel, and midfoot. Those are all CCs, but only if we have a description of the wound. And the description of the wound would have to be whether it was limited to the breakdown of the skin, if you had a fat layer exposed, necrosis of the muscle, or necrosis of the bone. I don't yet know who's going to be responsible for documenting this. I know with pressure ulcers, wound care specialists come in and give the staging. As long as the physician commented that, yes, indeed, they do have a decubitus ulcer, then we're able to report this a little bit better the staging and sometimes the exact location from a wound care specialist, and we were allowed to do that by CMS. I'm predicting that we'll have a similar rule, although I've not seen an encoding clinic yet, where wound care specialists might be able to come in and give a description of the wound here for us as well. The physician would still be responsible for documenting a non-pressure ulcer, and ideally, the physician would link that non-pressure ulcer back to, so if it's a non-pressure ulcer, then what did cause it? Well, was it, again, atherosclerosis? Was it a venous issue? Was it something like varicose veins? Was it just an infection? Underlying cause and the fact that they had a non-pressure ulcer, and then have the wound care come in and give a description. Beginning, however, so we get that guidance, it may very well be that the physician will be the one to query it. I think this will probably vary from facility to facility and physician advisor to physician advisor as to whether or not they're comfortable sort of assuming the old CMS rule for decubitus ulcers and applying it here, or whether they want to err on the side of being conservative and make sure that the physician also gives a wound description just in case CMS goes the other way with it. The documentation should still differentiate between these orders of glucose regulation and pancreatic internal secretion. Don't see a whole lot of these, but these are sort of, again, other insulin metabolic problems, increased secretion of glucagon, increased secretion of gastrin. I don't cross a lot of these, but it's good to have, especially the drug-induced hypoglycemia. I think that one would be one that we would probably see. Look at some examples of the ICD-10 codes in the expansion, and here, I think I've mentioned this a couple times, you have this code, diabetes with neurological manifestations, and that was it. It was one code, but in ICD-10, we know whether it was mononeuropathy, polyneuropathy, enteropathy, or other neurological complications. The chronic polyneuropathy is something that we've had in ICD-9 for a while. It never gets reported. You almost never see it. It's actually a CC even in ICD-9. It should also be a CC in ICD-10 if available. So if you know the neuropathy qualifies as the autonomic poly type, add into your documentation that moves us up to that moderate level of severity. So query for diabetic AD. When the patient has diabetes, ulcers, acute osteomyelitis, the care notes indicate decreased capillary refill and diminished pedal pulses, and AD is written in the chart. So I'm kind of getting the feeling that this is an arterial insufficiency, or at least a venous, if not some combination of both. And we're going to do the query. The codes that didn't work were the diabetic foot, diabetic osteomyelitis, diabetic with ulcers, and diabetic with cellulitis. So we went and we did this query. The physician said, yes, of course, it is diabetic PAD, and you can see we got over a half a day in our length of stay, and a good point and a half in our risk adjustment for that. Okay, we're moving along at a very good pace. So now we're going to tackle malnutrition and obesity. It's always a very controversial topic. I've had some facilities that were very good at capturing it, and I've had some facilities where even the physician advisor wasn't comfortable in the topic of malnutrition with a 10-foot pole. It's an OIG target diagnosis. It's a RAT diagnosis, and it's something that we have to defend if we're going to be reporting. So, of course, if we're reporting it, we do need to make sure that we have our evidence-based clinical indicators in the record, and I'll go over what those are in a few minutes. The provider should document malnutrition when appropriate and give the severity as mild, moderate, and severe. Moderate gives us that middle level of severity, and the severe gives us that highest level of severity. Obesity increases things like diabetes, heart disease, stroke, arthritis, some cancers. If we have a BMI of less than 19 or greater than 40, that by itself, just the score, will give us that middle level of severity on patients, but only if the physician also comments on the patient's nutritional status. So if the patient has a low BMI, the doctor will have needed to have documented underweight somewhere in the record, or anorexia, some kind of comment, something that goes along with that. It can't just be a low BMI and no other documentation. Same thing for BMI greater than 40. The doctor would have needed to have written at least obesity somewhere in the chart. And CMS has come out and said that obesity is a condition that is always significant and should always be reportable. Look, didn't treat it. Didn't do a bariatric procedure. We didn't do a lot of dietary. It wasn't the patient's diagnosis, but according to CMS, it adds so much to the length of stay, cost, the nursing care in particular, the nursing care being provided to that patient, that's always clinically significant and always meets criteria for reporting. So we put the diagnosis on there of obesity, and if it turns out that their BMI is also high, we have picked up a complicating comorbidity on that patient, just pretty much by default. BMI can be taken from an RN or a registered dietitian. Some cases can be taken from an automatic calculation, assuming we're smart enough not to do that on patients who are amputees. But again, the physician has to document somewhere in the chart whether they're obese or underweight. About 30% of the patient population, especially the elderly population, suffers from some sort of malnutrition, and it can go up by up to 50% during an acute illness, or if they have a severe long-term chronic illness. We don't capture it anywhere near at that rate, which tells us that there's probably an issue with how we screen for these, and probably a cultural issue with how we view whether or not we should address it. And I think there's also some issues where you have conflicts. Physician professional billing only allows them to document and bill for things that they are directly involved with, whereas hospital reporting requires us to report, we're required to report all of these conditions, anything that impacts the care of the patient whatsoever, all of it. And we're not really given we're in the latitude to just pick and choose. And so if they say it's significant, we're supposed to report it. And there you have a little bit of a sort of disjointed set of rules that aren't aligned very well. And I think that's why these conditions that we know occur more frequently don't get reported, and that's anywhere near that same level of frequency. It has received some additional attention in ICD-10. documentation for obesity should now, differentiate between things such as a localized adiposity. I guess that would be sort of the rear gut. Obesity due to excess calories, which would include your morbid obesity due to excess calories or with alveolar hypertension. And down at the next bullet point, other obesity due to excess calories. And you have drug-induced. We'd like to know the drug, of course, overweight, or whether it's unspecified completely. So I mentioned that I was going to come back to those evidence-based clinical indicators. I fought this as hard as I could in every conversation I had back in 2012 when it came out, but losing battle, mostly because RAC is now using these criteria as part of their reviews. RAC has figured out that these criteria are not in the records. They're kind of hard to capture, and so it gives them leverage to go and try to take the severity away from us, inappropriately, I might add, but we know that these diagnoses are out there, and we didn't just cure nutrition by creating a criteria that was hard to get documented in a chart. That's not how it works. But what we've got here is our severe, and I want to go ahead and go to the next chart. So this severe, and you can see, just going back and forth between the two, severe and non-severe have slightly different indicators, but let's talk about severe. You see down the left, we've got weight loss, energy intake, body fat, muscle mass, fluid accumulation, and grip strength, and across the top we have our chronic illness and injury in the middle, and then we have our acute on the left and our patient out in the population on the right. So what ACTIS has recommended is that you have a nutritional consult that they document according to this exact format in the progress notes, so that the CDI can then take that information and get that risk level from a dietitian and then incorporate that immediately into a query rolled up with whatever additional risk factors the CDI may see, and then funnel out to the physician so that the physician can make a quick and easy answer. Some of the things are problematic. For example, grip strength is not recommended in the ICU. Stimulation could very well be from another diagnosis, such as CHF or renal failure. If you have muscle mass depletion, it'd be very hard to determine that if you're only seeing the patients for 3 or 4 days, but we're not allowed to use old records in our querying, although I think a CDI could reference it for this purpose only, just in conversation with the dietitian and doctor. You probably, I hate to say it, but you probably wouldn't want to put that in writing just because there's some kind of, they get kind of funny when you reference old records. The doctor can reference the old records. The nutritionist may, but they're in the CDI cannot reference that history, even though the history is kind of required for this. You know if their energy intake has gone down and their weight loss going back for a 3-month period. Obviously, historical data is required. As their dietary intake, we don't know how much they really ate, how much the family ate, or if the person who wrote down what they ate was very reliable. There's just a lot of problems with using this, but because RAC is using it, we kind of have to play ball and try to document according to this format as much as possible. What I teach my CDS to look at, since some of those indicators are so unreliable, is to go and do a holistic review of everything going on with the patient and see if it sort of meets the smell test of whether or not they think this patient's at risk for a nutritional problem. And I've got some of the things on here. No problems such as malignancy and GI disorders. And if they have a malignancy of the GI tract, that is a double whammy, obviously. You can have things such as peptic ulcer disease, ileus obstructions, mucositis. All of those things are going to reduce the person's dietary intake, possibly chronically long-term. If there's status post-major bowel surgery, that issue with nutrition can go on for weeks, it can go on for months. Well, maybe they could also be a patient who had a acute mesenteric infarct and acute vascular insufficiency of intestine, but only a little bit of the intestine had to be removed, but now they're having chronic problems with nausea, vomiting, and loss of appetite. A disservice to the patient to ignore their nutritional status. If you had prolonged MPO status, I think that one's one that surgeons in the hospital, we're doing a much better job of getting that. We're beginning to realize the severe impacts to wound healing and the ability to mount a defense to infection just from even 1, 3, or 4 days without food. And so we're seeing a lot more TPA being given prophylactically to keep the patient from ever getting to that point, and that's great. Other risk factors would be things like a suppressed appetite, poor wound healing, if they're immunocompromised and anemic, if they are in a hypermetabolic state chronically, such as cancer, sepsis, COPD, whatever that might be, if they have dysphagia or a CVA patient, and if they're admitted. I'm sorry if I have another slide. Admitted and they come in and their electrolytes are just all out of whack too. Maybe they're an alcoholic and they're getting all of their calories from a bottle. Again, these are all things that CDS should be screening for that are sort of above and beyond just what's in those aspirin criteria. Socioeconomic issues, again, we know even from the Aspen research article in 2012 that these things such as an institutionalized state, financial difficulties, advanced age, cognitive impairment, these are all really, really high predictors of a poor nutritional status. And it may be that they don't look like the picture in the commercial of the starving child yet, but it's generally not good practice, I would say, to wait until the pathology has occurred and then give the patient the diagnosis. If they're already in the process of spiraling downhill, then it would be best to treat it before they get to that stage, and maybe you can prevent some of those complications and prolong life. So that's also one of the reasons why I am so aggressive personally in the nutritional state, because I don't think it's just good humanity to wait until after they've pretty much vaporized into a skeleton before you decide to call it what it is. Disorders, again, I mentioned this, that they come in and all of this is really, really off. Some of these things give us that middle level of severity, that sort of, that C itself. So if you're hyper or hyponatremic, that is just that moderately severely ill. And even things like magnesium, lights, potassium will give us some of that risk adjustment. Even if it doesn't meet the MSD or G definitions, it will meet the risk adjustment for things like HCCs, value-based purchasing, quality, and 3M's APRD or G system. So for us to always get those things. Up and down arrows don't work. Repeat lights or saying elevated potassium doesn't work. Giving the level doesn't work. You have to use the words hypo or hypernatremic, hyper or hypo, magnesium, so on and so forth. The sample query for nutrition. This patient had a BMI of 17.8, additional weight loss of 15 pounds in 6 weeks, and verbalizes a loss of appetite. We have them only eating 20% of their meals. And nutrition does rate them at risk and recommended. It also noticed that they were anemic, hypokalemic, and dehydrated on admission. So obviously there's some problems going on here. Terms that didn't work to capture the severity were weight loss, weakness, and debility. Cachexia by itself does give us that moderate or that middle level of severity, but what we're really looking for here is whether or not the patient's malnourished. You see at the bottom, the patient also has lung cancer. We did our query, and we were here because some of these indicators that we found do meet Aspen criteria and sort of their methodology, and the patient agreed, and you'll see that we've got 3 days in our length of stay, more than double our risk adjustment. Underestimate the malnutrition, maybe not in terms of the diagnosis that you're dealing with today, but how it's going to impact their readmissions, their ability to heal, and risk factor for getting sepsis in the next 90 days, and does impact those issues in a big way. I think a lot of the trend to sort of ignore the nutritional status has not served us well, honestly. So jumping into debridement, we have this also was one that we talked about in the surgical sessions. It's important to note that a lot of patients obviously can get debridement and they're just diabetics or they just have these ulcers. So we need to talk about it here too. It's defined as the definite surgical removal or cutting away of devitalized tissue. Note that the word excision needs to be present. The term incisional debridement doesn't. That will go to just a simple incision and drain. And if you just write debridement and you know anything else, it may very well go to a non-surgical debridement, which carries no severe risk adjustment whatsoever. So if you had to take a scalpel and actually cut around the wound, what we need is an excisional debridement. The term sharp debridement doesn't work either. What do we need is the method or technique, whether it was excisional or trimming, instruments used, scissors, scalpel. Location, appearance of wound was fresh bleeding viable tissue. The depth, when tissue was taken out, was the skin, fascia, muscle, or bone. We will only code to the deep tissue. So if you did debridement to the skin, to the subcutaneous tissue, that's what we're going to code. If you did bone, we'll go all the way down and code a partial osteectomy. Be saying debrided down to muscle because we don't know if you took out muscle or not. Best if you said down to and including muscle or down to but not including muscle. So we make sure we get the correct depth. Here is a query. This was probably a drive-by debridement that happens at the bedside quite frequently. And in terms of didn't work, or sharp debrided or wound debrided, sometimes folks just write debrided. The query is a little different. We don't use evidence-based clinical indicators. We're simply clarifying the procedure. So we want to know instrument use, type, depth, and location. And that we can code it. And it did turn out to be a surgical debridement. It met the criteria. And again, look at that, it's almost 2 additional days in our length of stay. And again, a lot of risk adjustment. You get a lot of risk adjustment from debridements because CMS has found out that the cost and the number of admissions on these patients is high. Acute blood loss anemia does not imply a medical misadventure. It may very well be an expected occurrence after surgery. However, it does increase resources and can add to the length of days. Examples of expected postoperative events that are not considered surgical misadventures could be something like post-laminectomy syndrome, just because it occurs after. In this case, even it doesn't mean that there is a surgical misadventure, and you won't get dinged for the diagnosis of acute blood loss anemia in any way. One around this, and when I did the surgical, when I did the ortho, I told them to just write expected acute blood loss. It was part of standard of care. It was not an unforeseen, but by documenting expected, we're covered on our quality metrics, but we also get this additional severity. A transfusion is not required to report acute blood loss anemia, but if they did get one, then that definitely goes towards the evidence that we're probably okay to report the procedure, report the diagnosis, unless it's something like a cabbage, where everybody gets blood transfusions, and then it's not going to be an indicator. We're teaching is a 2 to 3 point drop with evidence of significant bleeding. I want to see it go below 10 at least. Probably not going to do a 2 or 3 point drop if they're still up at 11 or 12. We're not going to query that. So look at the IV hydration. So if it dropped just barely over 2 points, but they got a ton of fluid and they bounce right back, again, I don't think it's worth pursuing the diagnosis in that case. Now, if it got down to like 7, it might be worth doing, even with the dilutional effects. That person probably got a transfusion too, though. Okay, just for any surgery, be aware, DVT, heart attacks, hemorrhage, wound dehiscence, bodies, those are all things that are patient safety indicators, and most of those things, not blood loss, but most of those things can be in our quality metrics. But we need to report them. We need the data collection, because how else can we fix it if we don't report it in the incidents? When it is, let's talk acute respiratory failure. Very briefly talked about this in the first half of the lecture, but remember, if the patient has an expected prolonged recovery time because they're end-stage COPD, that's probably not a respiratory complication of the procedure. That's just part of their medical issues. You can document acute respiratory failure without calling it post-op respiratory failure if you need to. Here is a query. Like ABLA is probably a misnomer, but the patient, this patient had acute blood loss anemia. Just ignore the word diabetes here. And they were in for an excision of the aneurysm of the heart. They had an expected blood loss of, well, not necessarily expected, but 1 liter, and got transfused 2 units, and they had a drop from 13.1 to 8.9. That's a good bit of a drop, even in the context of hemodilution. The two didn't work. Were blood loss anemia, transfused, or expected blood loss. What we needed to see was acute blood loss anemia. And you'll see that that gave us over 2 additional days and a portion of risk adjustment. This is something that in our surgical population, our patients getting major procedures, even in our GI bleeds and so on and so forth, is critically important to care, because it does really dictate the number of days. You know, when we see that their hemoglobin is stabilized and that they are on the mend, then we'll start making discharge plans if there's nothing else going on. But if it's not, then they're going to keep getting days added to their stay, and we're going to keep doing blood work, and we may keep doing transfusions. So it's a critical component to explain the clinical truth of their hospital stay. Surgical fractures. We have a bone fracture that occurs in the absence of trauma, which is very simple. When there's minimal trauma, a pathological fracture may be suspected. Also would be something that I would look at for patients who have severe osteoporosis, vitamin D deficiency, or some type of bone cancer. And it doesn't necessarily say zero trauma. It also says or minimal trauma. We'll talk about that here in just a second. The compression fracture cannot be coded as a pathological fracture unless the physician comes back and calls it a pathological fracture. The moment of injury and a close review of the radiology reports is what's going to determine whether the CDS or the CI gives you a query on this or not. But all fractures are going to be considered pretty much traumatic unless otherwise stated. Osteoporosis with a current pathological fracture is for patients who have a current fracture at the time of the encounter. Should be used for any patients with known osteoporosis who suffers a fracture, even if the patient had a minor fall or trauma. So what are we saying here? What we're saying is if the patient, if their mechanism of injury is not something that would normally result in a fracture in a healthy bone, meets criteria to call a pathological fracture. And their threshold that they give in the guidance is a fall from standing level. A fall from standing level should not usually cause a fracture in a healthy bone. And so even if they fell from a standing level, that can be considered pathological fracture. We see all the time patients who kind of slip out of a chair or slip out of a wheelchair or roll out of the bed. All of those should be identified as a pathological fracture as long as you know for sure that they also have a clinical diagnosis, also have that osteoporosis, osteopenia, brittle bone disease, some kind of a bone cancer. In those cases, we're okay to go ahead and call those pathological fractures. Now, a fall standing level because you slipped on ice, that's always a hard fall. You hit like a cinder block hitting when you slip on ice. So I probably wouldn't do that. But if you trip over a curb, I would consider probably something that we should consider a pathological fracture. If you fall down the steps, that's traumatic. But if you fall up the steps, it's probably pathological because you fell. It's kind of like leaning over into a chair. So keep that in mind when we look at these. Hopefully we can cut down on some of those queries. Here's the definition. Sustained with trauma no more than from a standing height or less occurring under circumstance that would not cause a fracture in a normal healthy bone. This is straight out of the ICD-10 definitions. They have almost the exact same definition for a fracture in a bone cancer patient. It's fracture due to neoplasm or something to that effect. Okay, speaking of neoplasms, remember that history cannot be reported as a current cancer site. History for any diagnosis in ICD-9 or 10 is reserved only for conditions that are completely resolved and are no longer under treatment. So if you're a problem list or in your H&P, you're writing history of, and you give that list. In that list, you give a lot of things that are still current conditions. And by that, I mean they're still on medications. Without medications, they would get sicker. That's what we call history in the coding world. Those are still active chronic problems, even though you may not be addressing them on your stay. We're required to report them if they're getting treatment, if you're going to do labs, if you're having to adjust the medications and consider all of those other conditions. Then you've actually done some evaluation and management on that, even though maybe you didn't realize you did it, and it's reportable. So remember that. So if a patient has an active primary cancer, active METs, or is an active treatment, the correct diagnosis is a malignant neoplasm. The example is of an 84-year-old woman, this is interesting, who had a mastectomy but is on tamoxifen. He can be on tamoxifen for, it's like 5 years. You're still able to report breast cancer as a diagnosis because you're still treating it or treating it from recurring. However, because of that practice, interestingly enough, breast cancer is one of two types of cancers that doesn't really count for any kind of severity. It doesn't give us a CC. The other one is prostate cancer, by the way. But still, this is a good practice. We should still call that under treatment for cancer, even though it's been cut out until such time as the medications are over with. A true history would be a patient with a history of colon cancer 8 years ago. It's been cut out. They've already been through their chemo and radiation. They've had no recurrence, and there's nothing else going on. That is a true history, and that's when we would use the term history. So for neoplasms, we need to know if it's benign, malignant, in situ, primary, secondary, if it is a neoplasm of contiguous or overlapping sites, for example, in the lung or the bladder or somewhere, and what type if possible. Avoid saying something like metastatic breast cancer or metastatic liver cancer. You will get a query saying metastatic from where or metastatic to where. We need both sites. Almost all of the cancers that I named out, all of the cancers that there are except the two that I named off, will actually move you to that moderate level of severity for your patient. So liver, lung, GI, bone, all of those are CCs. So we need to always capture both sites if it's metastatic, unless one site is truly resolved, and then we wouldn't catch it because it would just be history. Okay, jumping into psychiatric, two diagnoses that came up and under the category of psychiatric issues. One was depression and the other was substance abuse. We'll go through these very quickly. ICD-10 documentation needs to include the characteristics, whether it's major depressive disorder or single episode, mild, moderate, severe without psychotic features, severe with, and if it's single episode versus recurrent. Major depression, unspecified in ICD-9, has always moved us to a moderately severe patient. Let's face it, they're tough to deal with, and they may not take their medicines, they may be suicidal, they may not care, they may not listen to any of the teaching, puts them at risk for increased readmissions, and we have to do so much more work. So it's reportable. And as an ICD-10, it's not a CC. Unless you go back and say whether it's mild, moderate, severe, you have to give that specificity. They're not looking for the terms acute and chronic. They're looking for it written exactly the way that I've got it listed here. If it's a part of a problem that's going to impact their care, we should report it. Bipolar is another one that's often overlooked disorder. It's only CC if we call it a type 1, type 2, manic, mild, moderate, severe. If we use those terms, we say acute or history of or something like that, and we look and we see that they're on medications. They're having to be treated probably just like a chronic controlled bipolar. That's still a CC, but we didn't get it because the only thing in the chart was history of bipolar. And unless you think that dealing with that psychiatric component has no impact on the person's care and doesn't create any extra work at all, we probably try to get it measured. And we know that it always does impact. So here are some examples of the codes spelled out, so you can see. Third one down, bipolar disorder, current episode, manic, without psychotic features. It's CC. They're manic, even they're not completely psychotic. Bipolar disorder, current episode, depressed, mild, still CC, still moderately severe. Schizophrenia, in ICD-9 we report schizophrenia with type and acuity, and ICD-10 is only reported by type. Something like the acute schizophrenia, the severe schizophrenia, that would have counted in ICD-9, but in ICD-10, what we really need to know is if it's paranoid, psychotic, simple, disorganized, etc. That gives us that moderate level of severity. Here is a list of everything that counts as CCs. Again, major depression is documented. Bipolar, as long as we got the recent episode or the manifestations. Acute paranoid reaction, all types of schizophrenia, as long as we have the type. I think I mentioned that. Alcohol and drug withdrawal, tobacco withdrawal is actually going to be a CC in ICD-10. Interesting, we never even had a code to report that before that I can think of. And then any kind of continuous drug use, continuous abuse, drug dependence, those things will always also count as CCs, which brings us into this one. Substance abuse and dependence, we need the pattern. Is it abuse or use? Alcohol is something that it can be just casual use and not really need to be reported, or not need to be something which will capture additional severity on the patient. I think we're having this discussion in the future about marijuana. Right now, any drug that's considered illegal is automatically considered to be abuse, no matter what. Even if they smoke it once every 6 months, it's abuse. Once it's legalized, different story, and that's going to be an interesting discussion that we'll be having. If they're using it in a dysfunctional behavior, even if they only use it once every 3 or 4 weeks, but they drink to intoxication, that's abuse. If they drink to get drunk, it's abuse. If they drink just to have a couple of drinks to be social, it's not abuse. Where we really are looking to really capture this, though, where it's really impacting them, is when they have the dysfunction that approaches dependence. And we consider dependence being a thing that creates a physiological dependency, meaning they would go through withdrawal if they stop taking it. We definitely want to capture all of those as dependence because that puts it to that moderate level of severity. So if there's going to be any withdrawal symptoms, we need to capture that if they are really hooked on it. And you can even see that in episodic use with alcohol where they are a weekend binge drinker. You go 2 or 3 days on alcohol without going in the withdrawal, and then so the weekend starts on Thursday every week. They're episodic use, but they're actually alcohol dependent. So in those cases, because if you stop doing it on weekends they go through withdrawals. So in those cases, we should report it. Manifestations that they would have, such as coma, seizure, respiratory failure, I'm going to add malnutrition to that one. If they aspirate, if you have to detox them, now to order the detox, if we actually have to give the meds and they show the signs of both withdrawal and detoxification and give treatment, then we should report all of that. The one thing that we're missing a lot of times is we can see the usage pattern, how much they do every day is usually in the chart, but the word that we need is continuous use. Continuous use meaning daily use. Then we need that bit of documentation that really helps us in reporting that dependence with continuous use. Most commonly seen in your pain pill users and some of your narcotic dependencies. So that's what I've got here. Also, if it's remission, that's fine. It can be alcohol dependence in remission. We can do it that way. The narcotic dependence now in remission. I pretty much covered a lot of this. So alcohol withdrawal is also another one that gives us our CCs. Delirium tremens even gives us even more risk adjustment, obviously, because it's kind of rare and it's very serious when they have it. Of increased specificity for these would be opioid abuse with opioid-induced psychotic disorder with delusion. So now we've got combo codes that are relating to behavioral manifestations to the substance issue, and that's really good. The next one down has psychotic disorder with hallucinations, and the other has an opioid-induced psychotic disorder. I think a lot of people probably have some of that going on, and we just assume that they're typical behavior for patients that we have to deal with in the hospital, but in reality, that might be typical behavior for them. And they have other medical problems going on too, and they're acting out, but it very well may be related, or it's not helped, the fact that they are on opioids continuously and or dependent. So this is a way to capture that in the combination codes. So how did we do on time? Okay, about 7 or 8 minutes to open it up for questions and discussions.